University of Rochester Medical Center is the clinical arm of the University of Rochester. It's comprised of multiple hospitals, long-term care facilities, UR Medicine home care, as well as an extensive network of primary care providers.
The Critical Illness Recovery Program is a collaboration between the inpatient hospital and home health care setting that really targets patients who've survived a prolonged stay in the intensive care unit. These patients are particularly at high risk for post-intensive care syndrome, which is a syndrome known to affect patients in a way that they develop multiple different deficits that could be physical, cognitive, psychological, that we know are associated with prolonged critical illness.
The University of Rochester has been committed to this population for some time, and several years ago had committed resources to develop a facility-based clinic called the PICS Clinic. But one of the challenges was that the population, being a very frail and ill population, had difficulty getting to the clinic to receive the services that were available. At the beginning of the COVID-19 pandemic, there was a striking increase in the number of patients that were being admitted to the critical care unit and who were going to be at risk for PICS. The PICS clinic had been closed and the number of patients that were filling our ICU beds was rising. It seemed the crucial time to address the challenges of patient access that were being experienced in the facility-based clinic and think of maybe some new ways to serve them.
We knew there would be a big gap in the care of these patients. We knew we could take care of them in the hospital, but what happens when they leave, and who's going to make sure that they're getting back to their previous health? What UR Home Care adds to this is the ability to meet the patients where they are, right in their home after their critical illness, which is much more practical for the patients to get what they need. It also offers the ability to start immediately after their hospital discharge. Often with our facility-based program, it would be weeks before they could get in to see us. Here, we have a multidisciplinary team that goes into the patient's home immediately after their discharge, and therapy starts on day one. One of the key features of the Critical Illness Recovery Program is that it is so multidisciplinary. It involves physicians, it involves ICU nurses who are looking out for patients who might meet criteria. It involves our care coordinators. It involves our critical care pharmacists who need to make sure that these patients go home on the right medicines and that there's no drug interactions and that they're up to date on their vaccinations. It involves an entire home care team, which includes nursing, physical therapy, occupational therapy, speech therapy, social work, and others. It involves our outpatient pulmonary clinic, which facilitates and organizes all of these telemedicine visits that are part of the Critical Illness Recovery Program.
We knew that a different approach had to be explored for this group of patients. We also had kind of a rigorous approach to deploying our rehabilitation services so that we could address their functional needs, as well as monitoring the patients with regards to their shortness of breath and a lot of their pulmonary symptoms. And so we wanted to make sure that we were demonstrating that they were either having progress or they're still having some challenges. The real game changer to this program, though, was the fact that we closely integrated our home care team with the hospital providers. And this was not only in terms of information exchange, so what our assessments were in the home, being able to communicate that back to the hospital providers, but also ensuring that they had follow-up with the specialists that took care of them in the intensive care unit. And that really aimed to us developing a telemedicine approach to having a follow-up visit so that the patient and their caregivers in the comfort of their own home could be able to connect with the hospital providers. And they didn't have to have the challenges of having to navigate back into a hospital clinic.
Communication is very important. The exchange of information, the timely initiation of care, because patients need service. They can't wait for service, especially when they need physical therapy and occupational therapy, or they have a complex medication regimen. They really need attention immediately so that things don't veer off course. Some of the greatest successes for the Critical Illness Recovery Program and the collaboration with the Medical Center were maintaining open lines of communication and the seamless coordination of care across care settings.
One of the things that we have been tracking from the very beginning is the readmission rates for patients who go through this program. The idea at the beginning was that if we could meet people where they were, if we could help to intervene sooner, we would be able to help people in their recovery and help keep them home. And the readmission rates for the program have been very, very promising. This population in general, readmission rates can be as high as 20%, and in 2021, our readmission rates were consistently under 10% or even lower throughout this entire pilot period.
In our first phase of the pilot of this program, we only had one rehospitalization that had occurred, and that was really kind of shocking to us.
We are starting to look at the OASIS outcomes for these patients. The OASIS is the outcome and assessment information set. This is a scoring tool used in home care, and it is completed at admission and at discharge. And there's very encouraging preliminary data showing that this patient population has improved functional outcomes.
I think successes are measured patient by patient, one patient at a time. By the time I see them at their telemedicine visit a week or two after their hospital discharge, they're already on the way because home care has already been there, gotten started, physical therapy's underway, their occupational therapy's underway, they're getting nursing care, they haven't come back to the emergency room or the hospital, and then seeing that mature further at the 90-day telemedicine visit is really something that's a great privilege for me to be part of, because they do get better, they do return to their baseline. I think it has a lot to do with that initiation of care immediately after their hospital discharge. No lag time, no 2-3 weeks to sort of flounder at home.
From a health system standpoint, we do a very good job in the hospital of stabilizing the patients and getting them on that path of recovery, and that needs to continue then as they transition to home so that they can achieve really a level of independence and safety at home and reduce the risk that they have a decline in their clinical condition or have to return back to the hospital for rehospitalization.
I think partnerships between home health care and hospitals are important for sharing of information. We know that sharing of information improves patient safety. We know that it improves communication. I think it's also important to prevent medication and medical errors that occur between transitions of care. So having that relationship and partnership will improve that communication and sharing of information.
From my perspective, home care affords the ability to initiate post-acute care in a timely manner and in the home setting, so the patient does not have to struggle with making appointments or transportation. They're homebound while they are still recovering, and we meet them where they are.
I think by all measures, the critical illness recovery program has been a success. That success, I think, is feeding other initiatives to partner with acute care in the hospital and home care. And so I think this model is going to grow.
I think this is a model that can be used even outside of this area of post-intensive care syndrome, that we're looking at patients that particularly are most vulnerable because of an acute event like a stroke or illness, heart disease, and those sorts of things, that are patients that are at high risk for being rehospitalized. And can we develop a more coordinated and collaborative kind of approach to these kind of transitions of care? Home care is really one of the early interventions as seeing that patient immediately after discharge, within days of that discharge, and being able to identify any particular needs or risks for that patient. The future of this program is, I think, really bright. I think we have a lot of opportunity here.